Okay, so let's learn about pre-eclampsia as we have discussed in previous lectures. What is pregnancy induced hypertension, what is gestational hypertension, what is preeclampsia and eclampsia, and now we are going further in details of preeclampsia. So we have discussed according to DC Datta definition of preeclampsia. Okay, so that's essential for exam. Okay, follow that. Let's discuss again as the sum of, like, what is that hypertension to the extent of 140 by 90 mmHg or more in preeclampsia, but after 20 week of gestation. Why 20 week of gestation? Because placenta, spiral artery, blood circulation, maturation will be developed by 20th week. Okay, in that, in preeclampsia, we can be seen edema or excessive weight gain of that particular pregnant lady who prone to preeclampsia. Also proteinuria or albuminuria gain. Okay, why this happen? Let's see. Okay, so that's the causes of preeclampsia. And okay, as I said that exact etiological main cause of preeclampsia is still unknown, but there are some basic theories which followed in preeclampsia. So these are some things: damage to blood vessels, genetic factors, insufficient blood flow to uterus, immune system problem. Okay, but what is a main theory which follow in preeclampsia? So this etiopathophysiciology in preeclampsia. So mainly what happen? Uh, Abnormal development of placenta. Okay, abnormal development of placenta, which leads to what? Leads to that spiral arteries. Okay, spiral arteries. Okay, in preeclampsia we have discussed that when placenta develop and after that spiral artery development, that is essential for uteroplacental circulation. Okay, in between uterus and placenta. But in abnormal development of placenta, when capillary spiral artery development fully not developed, then vasospasm means vasoconstriction happen. Why? Because insufficient length of spiral arteries, that may be platelet aggregation. Okay, so that affect uteroplacental blood flow. Okay, now in order to prevent vasospasm, okay, vasospasm, nitric oxide release. Okay, why? Because nitric oxide has properties, nitric oxide. Okay, if you know that nitroglycerin function, related nitro oxide, which has properties of vasodilation, which helpful to dilate blood vessels. So it failure to vasodilation, now nitric oxide now reduce. Okay, why? Because abnormal development of placental capillary spiral arteries. So nitric oxide function now, because in normal vasodilation, platelet aggregation but in a normal amount, in that platelet aggregation in a high amount, uteroplacental blood flow. Okay, mainly as per the criteria. So nitric oxide remains same, but in this nitric oxide reduce, that leads to endothelial dysfunction. And now what will happen? Endothelial injury. Now endothelial injury happen, then eventually what? Inflammation happen. And then if inflammation happen, then aggregation of platelet in order to save the endothelial blood vessels regarding uteroplacental circulation is now increased platelet. Okay, so there are some enzymes which release that factors that are currently thought to cause endothelial dysfunction: lipid peroxide, reactive oxygenation species, and cytokinase, IL-6 and TNF effector, okay, which release arachidonic acid, essential fatty acid, with the help of enzyme cyclooxygenase, prostaglandin PGI2, prostaglandin PGE2, and thromboxane enzyme TXA2. This happen when endothelial dysfunction, endothelial injury happen. This is a called inflammation in blood vessel, especially where uteroplacental blood flow at spiral artery, spiral blood vessels, capillary circulation. Okay, for that, what happen? Angiotensinogen liver, okay, which is angiotensinogen produced by liver, which converted into angiotensin 1 and 2, that leads to more and more endothelial dysfunction, which increase hypertension above 140 by 90 mm Hg. In preeclampsia, 140 by 90 mm Hg, more blood pressure we can be seen. In systolic, plus 30 mm Hg. If some lady has preeclampsia and has systolic blood pressure more than 140 mm Hg, then it will lead to up to 30 mm Hg, like 170 mm Hg. In diastolic, that will be plus 15 to plus 20 mm Hg, okay. But that in normal condition, mean arterial blood pressure 93.3 mm Hg, but in preeclampsia 105. Okay, in preeclampsia systolic up to 1 plus 30 mm Hg, diastolic plus 15 to plus 20 mm Hg, and mean arterial blood pressure up to 105 mm Hg. In normal condition, mean arterial blood pressure in normal condition 93.3 mm Hg. Okay, how we can measure mean arterial blood pressure? So systolic blood pressure plus 2 into diastolic blood pressure upon 3. Okay, that's the formula of mean arterial blood pressure. Okay, now preeclampsia has two types, minor and severe. Okay, minor means 140 by 90 mm Hg to 160 upon 1110 mm Hg, that is minor, and then more than 160 upon 110 mm Hg, that is called severe preeclampsia. In severe preeclampsia, there is extreme vasoconstriction, blood vision due to retinal attachment. Okay, now what happened next? In excessive blood pressure, liver and kidney function going to fail. Why? Because if angiotensin 1 2 increase, then eventually liver metabolism dysfunction happen. SGOT AST enzyme and SGPT ALT enzyme eventually increase, which in normal vessels, okay, non-hypertensive vessel, SGOT value is 5 to 40 international unit per ml. SGPT normal value 5 to 56 international unit per ml. Okay, but in preeclampsia it will be goes up to 70 international unit per ml. Now free radicals of SGOT SGPT means ALT AST enzyme, if you know that these are enzyme which helpful in our metabolism, okay, bile production. If you learn bile and bilirubin, biliverd in circulation, okay, then you get easily know this. Now this free radicals formation H2O2, which eventually more damage endothelial, and now capillary permeability increase, capillaries rupture, and that intracellular intravascular fluid, both intracellular and intravascular fluid shift into extravascular and extracellular fluid, which leads to retention of fluid edema. Okay, so what happened? These more fluid free radicals going into kidney. In that kidney, that free radicals, that fatty acids plus free radicals form the low level of protein, more and more protein, which affect glomerulus, and eventually we can see proteinuria. Okay, so what happened in preeclampsia? If placenta dysfunctional, placental improper development which affect uteroplacental spiral artery blood flow, okay, which leads to increased tension in endothelial spiral vessels, okay, which reduce nitric oxide level, which vascular refractoriness to pressure agents, endothelial dysfunction, vasoconstriction happen, that angiotensinogen level increase, angiotensin 1 and 2 eventually increase, liver affect, AST-ALT enzyme increase, metabolism increase, fluid retention, capillary rupture, edema can be seen, free radicals move into kidney, protein fatty acid increase, effect on glomerulus, and more protein can be seen in urine. Okay, so that happen in preeclampsia. Okay, level of protein, like classification according proteinuria, in trace 0.1 gram per liter, then plus 1 degree proteinuria, 0.3 gram per liter protein, plus 2 degree proteinuria, plus 1 gram per liter protein, plus 3 degree proteinuria, 3 gram per liter, plus 4 degree proteinuria, more than 5 gram per liter. That these are severe eclampsia, these are minor preeclampsia. Okay, next we will learn about management of and sign and symptoms of preeclampsia and also diagnostic criteria of preeclampsia. If you have any doubt, you can comment. Till then, happy learning.